Hello, this is Scott McDonald, and welcome to Dr. Demographics podcast on where to put a practice. Now, as you probably know, we're not just working with one particular type of professional healthcare practice. We do all kinds, including for dentistry, physicians, specialists of all kinds, and we do it in every neighborhood of the United States. So with that in mind, we're taking kind of a broad view of the whole country, but we also are trying to provide enough information that is specific to healthcare practices, meaning doctors and doctors who own their own practices. Now, I've got to tell you, I've been doing this for a long, long time, and some of the things I'm telling you are not what other people may incline to tell. And I mean specifically, there are those who want to take demographic information and assume that you, the consumer, understands what is a reasonable amount of growth, median household income, the distribution of population based upon the housing type. I mean, that's good to know, but they're sort of assuming a lot of heavy lifting for you. When we do a report, we're trying to interpret the data not only for doctors in general, but also your specific kinds of practices. So you got to tell us a little bit about what you're looking for, and we can help you determine the viability of a particular site. That's kind of our job. Now, with that in mind, let me kind of start off with something you want to know. It surprised me when I found out that when people were trying to figure out the viability of a practice site, they certainly knew that you got to take in the number of providers of your type within a geographic radius. But it's not just the providers, it's who lives and works in that area. And this is what we call daytime population. A successful evaluation of a practice site's viability must take into account the employment data. It's not enough to say, oh, well, people always come from home to get to our office. The viability of a site is often tied to other factors like how many people are there before work, during work, and after work. What are they doing, and how do you evaluate the desirability of that population for your practice type? Now, patients tend to come to a practice's site from work and from home. Now, I say that because for many years, there was the assumption that people only came from home. Well, because of the length of treatment, diagnosis, and a variety of other factors, people are often coming from work and they're going to the doctor, and then they'll return to work, or then they'll go home, or they'll come from home and then go to work. Then, well, you get the idea. Competition ratios have traditionally, as I said, only taken into account the ratio of providers and residents. And that gives you a false positive or a false negative about the viability of the practice. Workers are much harder to track, as we'll see, than residents are. Now, it's easy when you assume that every resident is pretty much the same. But in fact, they're not. And the people who work in an area have different kinds of professions, as we will discuss. And therefore, the availability of that population to come in for treatment or follow-up matters a lot. Now, here's something I want you to keep in mind. Things have changed. It used to be nobody would ever come to an office directly from work. They would tend to take the end of the day and then go in to seek care or treatment or a diagnosis. But people are interested in different day parts. So people want to come for treatment before, during, and after their workday. And typically the kinds of procedures that we're seeing are not going to be the same. Now, this is going to vary, of course, based upon the type of practice you have. But if you're coming in for pediatric care, you've picked a child up and you've taken them with you and they're there. Sometimes the child will be there at the same time waiting for you to receive your treatment. Maybe not. But it also counts as to the invasiveness of the procedure, including the diagnosis, to see, is this going to be a good idea or not? From the point of origination, that means where people come from, and where they are going to, their point of departure, it's both complex and it's shifting. Now, when I was working in New York City, I noticed that it was very different from what we were seeing in California. And of course, places in the Midwest, places that are of low population density, that are more rural, for example. Well, it makes a difference as to the viability of a practice to draw people other than from their homes. So we want to inform you of that through the examination of various factors that you should know about. Now, this is especially true for pet owners, commuters, optometrists, and emergency patients. Now, stick with me. There are a lot of people who want to take their pet companion to the veterinarian. Obviously, it's going to be better for them to be able to drop their pet off. And then, even though the doctor may not see that pet, they're going to have short-term kenneling, let's say, or housing for that pet until they can receive treatment, and then keep the pet until after work when a client can pick the patient up. Optometrists were generally considered to be highly non-invasive, except when it came to dilation of the pupils. That kind of messed up your day if you're having to go back to work. But because the technology has changed for dilation, for example, it makes a difference as to the viability of doing this during the day. There are some commuters that it was possible to have them go before work or after work, but it was not possible for them to go during the day, during the workday. But the commute patterns in the United States have shifted based upon population density and other factors. So we now have to look at commuters differently than we once did before. Patients were always considered those who were at the extreme ends of the day. So you'd have a patient who'd come in early in the morning, first thing, and then other times you'd have patients that would want to come at the very end of the day. That's what we mean by emergency patients. It isn't that they're bleeding. It's often that the hours of operation have to be taken into account. Knowing this makes a big difference as to the viability of your practice site relative to the commute path, the kinds of diagnosis, and the kinds of treatment they might receive. Two-career households have made this much more complex. There used to be a time in which, mom would be home with the kids. But that isn't happening so much anymore, and two professional homes are quite common, or two career homes. And knowing that is making a difference as to the hours of operation and the kinds of treatments and diagnosis that you're going to be offering to people. Now, believe it or not, a demographer can look at the potential patient base within an area and determine the day parts, the times during the day, and even the treatment and diagnosis that might be offered. And it's a little complicated from what it used to be. When there are multiple cars in a family, this isn't an issue, but there are a lot of people who are dealing with their commute through mass transit, and some people are sharing a car. All of these facts can be known demographically, and we can predict what the likely outcomes are going to be and the potential for your practice under these circumstances. Now, urgent care issues are really going to be an answer for a lot of people. And I mean by this, extended hours, if you were to offer a late day, often a Wednesday, let's say, might be an answer to a lot of people who are in urgent care environments. There are lots of people who will have transportation issues. So extended hours becomes a thing. Shorter appointment wait times is also another answer for this, but that's not possible everywhere. So that's why you want to understand where people are coming from, why they are there, and where they're going to go after they see the doctor and come to the office. This is complex, but it can be determined demographically what is going to be the best answer for you and your practice. Now, I got to tell you a couple of things that you should really know. Look, bankers' hours are dying. There was a time in which you had to come in to a doctor after 10 o'clock in the morning, and you'd have to be out the door by 3 or 4. Those were bankers' hours. That trend is dying, largely because of automation within the administration of the practice. So look, you've got very expensive diagnosis equipment in your office. you want to make sure that you're utilizing that effectively to make sure that you're paying off that very expensive piece of diagnostic and treatment equipment. So that's a good reason why bankers' hours are not working. But it's something we have to take into account based upon your preferences and the kind of practice you have, treatments and diagnoses that you're going to be able to offer to people. I hope you all are clear on that. Now, referral networks and the relationships between providers and insurance companies and other networks is really shifting a lot. It isn't the same as it used to be. The mechanics of referral are in flux. So it used to be a time that you would never see a patient for an extended treatment unless you'd actually had them in the office. Through telecommunications, including Zoom and other factors, you're able to talk to the patient before, during, and after regular treatment hours. So therefore, the referral network and the diagnostic relationship are shifting. This means the hours of operation are going to shift, and the nature of utilization of your staff is also going to shift. And I think this is, if anything, going to accelerate in the near future. Now, the reinvention and redefinition of appointments are changing. Now, as I was kind of mentioning, telemedicine is becoming much more common. So a doctor or other staff persons will be able to talk to a patient face to face and communicate with them as to what their condition might be and what they suspect their needs are. This goes a long way to make people happy. But it also provides doctors and their staffs with the ability to see a lot larger number of people without long wait times in the operatories or in the patient rooms. So given that that's the case, it's changing a lot of things with how providers are seeing patients before, during, and after business hours. Now, there's a term I want to use called daytime population. This is the definition within a drive time, or it's defined within a drive time. So stick with me. There are three things about the daytime population you have to understand. They're not people who are sitting at home waiting to come in and see you. These include people who are residents. They are workers, or in other words, people who are employed, sometimes in another office, sometimes at home, or shoppers, people who are, well, I'm going to put that down as just people who are doing other things with their day. So residents, workers, and shoppers altogether define the daytime population. But you have to keep something in mind. They're not mutually exclusive. These are people who are going to, well, do one thing and then another. They may be shopping, they may be working, they may not. And these are facts that you need to keep in mind. Now, there's a variation within the employment types. There are white-collar workers, blue-collar workers, and service sector workers, sometimes called gray-collar. Now, it doesn't necessarily mean that white-collar people are making a lot of money and blue-collar people are not. A study was done just a few years ago to show what kinds of insurance benefits were most available, and union blue-collar workers were the ones who had the best insurance for healthcare almost every time. That doesn't mean that white-collar workers aren't desirable. It just means that their schedules and their insurance types are different. Now, as for service industry people, these are very often people who are skilled professionals, like mechanics, who are working within an area, and their schedules are a little bit different, and the way that they charge their employers for their services also vary. But you can know the percentage of white-collar, blue-collar, and service sector workers there are within an area, and you can make your plans for how your practice schedules patients accordingly. Please do not make the assumption that they're all good or they're all bad. They're not. Don't assume anything about their desirability. Now, we've talked about the kinds of people who are working in a particular area, the employment base. And the employment base is most often determined by drive time. In other words, how long does it take to get from their work to your office. It's very easy to do that when it comes to knowing a person's zip code of their residential home, but that is not always something that is known about their place of employment. So it presents an opportunity and a challenge for you to know. Population type, we also want to take into account their lifestyles or their housing type. Now, COVID-19 made things a lot more difficult. It used to be that you had to go to work every day by commuting. Doesn't happen quite that way. But we are seeing people who live in single-family dwellings are far more likely to telecommute than people who are living in an apartment. That's not true every time. It's just a tendency or a likelihood. Now, if we define single-family dwellings, there are two ways to look at it. There's owner-occupied and renter-occupied. People who are owner-occupied have far more control over their income, but also their credit. People who are owner-occupied residents of an area have much better opportunities to get good credit. People who are renters do not. I'm not saying that they're not good patients or they're not desirable. I'm simply saying these are facts about the population that matter. Another way of looking at the housing type is multifamily dwellings. We know that there are low density and there are high density. You take a low density, might be a duplex. So they're living in multifamily housing, but there aren't very many people per square mile or per square block. They're low density housing people. High density are going to be those living in high rises. Now, low and high density populations, you can generally say if it's a 2-story dwelling, they're low density. And that's a general truism. Not true every time. If you happen to have more than 4 levels, or let's say 4 floors, they tend to be categorized as high density. And of course, there are things that mix. But the people who live in high density housing are not living the same lifestyles as those who are living in low density housing. Availability of parking, for example, in low density housing is far greater. And it means that you can zip over to a doctor's office much quicker if it's in a low density area. High density, that calculus changes. We know that in California, they are getting rid of low density mandates, meaning before you had the ability to have a single family dwelling in a single family residence on a single family block, a block filled with low density populations living in their own homes. But California is making that so that they're getting rid of it because they believe the land use hasn't been wise. So in other words, they're making it so that a person who was previously living in a single family home can now subdivide their property so that 4 dwellings are now found in that space. I'm not going to say anything except I think they're crazy to do it. But we're also noting, by the way, that when this happens, more and more people are moving away. That's because there's a truism. People want to live in their own single family dwelling, and they don't want the option or take the option from them of being able to do that. We'll talk about it some other time. Now, if you want to find us at Dr. Demographics, please visit our website at drdemographics.com or write to info@drdemographics.com. Our toll-free number is 833-424-6222. And a lot of times what people are doing these days is they're giving us a call and arranging a telephone consultation. So if you want to know what are some areas that might work for you, what recommendations do we have on states or counties, a telephone consultation might be a pretty inexpensive way to get information, but I strongly recommend you have a written report that can be more detailed and project more into the future. This is Scott McDonald. I want to thank you for watching. We have a much shorter version of this, a 5-minute briefing, so to speak, on this topic. Check us out at the website at drdemographics.com. And thanks so much for watching.